All right, well, I'm Diane Hall. I've been involved, all I know, my whole career is long-term care. Started off 36 years ago as a dietitian and a certified dieting manager, and worked myself up to an administrator. And since 1992, I've owned my own company, Balance Senior Nutrition. And what I'm going to do for the first couple of minutes is all right, there's the curtain, and there's my company. We're a group of dietitians consulting in Florida and Virginia. And I'm very involved with the Florida Pioneer Network in Florida as their chair, an advocate of the dieting standards. Ooh, every time I push this, I'm sorry. This is going faster than I want it to. We'll start over, okay. So, the only way I know to explain the change of diets and the culture change of diets is to tell you a few little stories of the culture of diets back in 1980. In 1982, when I started, it was all about quality of care. And what I mean by that is we had a patient, it was a German lady, who stopped eating. And we decided, well, since this puree isn't working anymore, we'll liquefy it. And then we'll put it in a big old syringe, and we'll stand over her, and we'll squeeze the syringe, and this liquefied puree will go down her throat, and she'll get nutrition. And we will not allow her to lose weight. So we pretty much force-fed. How many folks I must have caused to choke and aspirate without knowing, I'm afraid to think about. But back then, we didn't want anyone losing weight on us. There was another incident that I remember and feel guilty about, and that was NG tubes, the nasogastric tubes. We used those years ago in the 80s, and well, sometimes they'd be in for a couple of weeks, sometimes a couple of months. Sometimes these folks would have those nasty, hard NG tubes for a year or two. And oh, what do you mean it bothered them? And what do you mean they tried to pull it out? Well, we fixed that too. We tied their hands so they couldn't do that. You see, it was all about taking care of people back then. In 1986, the Institute of Medicine wrote a report to Congress, and it was called Improving Quality Care in Nursing Homes. 1 year later, Congress wrote the OBRA, Nursing Home Reform Act. Anyone familiar with 1987 OBRA Reform Act? What that said, in a nutshell, one key sentence from there says, because most nursing home residents live in nursing homes for many months or years, quality of life is as important as quality of care in these institutions. That was in 1987. In 1986 is when I became an administrator. And I remember learning from an older administrator, Maureen Laverty, said to me, now Diane, don't learn the hard way, but you know all this talk about OBRA and quality of life? I had an old lady teach me years ago to pretty much mind my own P's and Q's. They had coffee available for everyone in the morning and donuts. Well, Maureen, being an administrator, says to this lady, excuse me, you can have the coffee, ma'am, but you're diabetic, you're not to have the donuts. Well, apparently, this little old lady turned to Maureen, and in so many words that I can't say up here, put Maureen in her place and said, nobody, blah, 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 is going to tell me what I can or cannot eat. So early on, I realized that there was more than just quality of care, and that the regulations were going to support that. Move ahead 10 years later, 1997, so we're going back 20 years ago, the Academy, which was the American Dietetic Association, wrote a position paper, and it said, there's no real evidence that NCS diets control diabetes and is a good idea in nursing homes. That was in 1997. That was our own academy writing a position paper. That same year, I had an experience with an activity director and a resident named Mary. Mary had diabetes, was new to the community, happened to come in while we were having our monthly birthday party. And they said, since you're new, maybe you would like to be the one that, cuts the cake. So, and I witnessed, these are all true stories. So she's cutting slices of cake for everyone. And then the activity director turns to her and says, oh, Mary, wait, you can't have a piece. I'll get you some fruit, but you're diabetic and you can't have it. And Mary happened to want it, a lot, but she wasn't allowed to have it. I guess the community had been cited a couple years earlier for not following diets. So the activity director stuck to her guns and took good care of Mary. And Mary, can you imagine how she felt as a newcomer and her birthday month and not being able to have that birthday cake? So moving forward, 2010. Probably the most profound thing happened to me, enough for me to stop, change my company's name, and really change why Diane Hall is still in the industry and what I wanted to do for the industry. I had an experience with an administrator called me, asked me to come to a ethics meeting about Mr. Parkinson's. Mr. Parkinson's was a 90-year-old gentleman in stage Parkinson's disease, had taken ill. The therapies come to Mr. Parkinson's bedside, speech therapy, does a bedside swallow, discovers he's having a hard time with thin liquids. So, boom, called the doctor, ordered thickened liquids. Mr. Parkinson's wasn't asked. Mr. Parkinson's didn't want the thickened liquids. He had lived in this community for 5 years. He was used to going to the dining room, breakfast, lunch, and dinner. So he would go, and they'd give him the thickened water. And he'd say, I don't want thickened water, I want my ice water. Sorry, Mr. Parkinson's, you gotta have the thickened water. This went on and on and on. He became really focused and adamant he wanted this thin water. He became obnoxious, basically, in the dining room. So what did the staff do in their wisdom? Mr. Parkinson's no longer appropriate for the dining room. So now he's eating in his room. What do you think happened to Mr. Parkinson's? He loses a significant amount of weight. Now everybody's a little bit concerned, right? We have to answer this weight loss. So they called this an ethics meeting, but it was a risk meeting. Mr. Parkinson's was not involved with this meeting, nor was the attending physician, nor was his family. Diane, being the pioneer I am, came armed with that ADA position paper. You've got to liberalize. I came armed with the interpretive guidelines for the federal requirements saying you can get a J tag. Everyone know what a J tag is? Jeopardy, the worst you can get. If someone loses a significant amount of weight because they're on a diet they don't want to be on. So I thought I had it in the bag. I walked in with all my papers and sat in front of the medical director. We had the regional administrator. There was even somebody on the speakerphone, I think an attorney. What are we going to do with Mr. Parkinson's? Because the physician was refusing to change the order. What would you do? Well, I thought, well, let's make him terminal. Let's do this, let's do that. Everything I thought of, basically they said, Diane, you're talking, thinking with your heart, you're a nice little girl, but you need to sit down. We can't just, the doctor doesn't want to change the order, so we just can't give him thin liquids and watch him choke to death. So what we're going to have to do is discharge Mr. Parkinson's because we can no longer take care of his medical needs. This was 2010. I've been involved since 1982. It was winter, it was dark. I would go to my car at 6 o'clock. I get in it, and tears are coming down my face. Very profound moment for me. What I haven't told you is, guess who Mr. Parkinson's roommate was? Again, a true story. His wife. Okay, so he's 90 years old. This is his home for 5 years. He knows the staff knows him. He's living with his wife. He just wants ice water, and they're going to discharge him. And this is United States. So what happens, he was pretty ill, so instead of just jumping on that 30-day letter of discharge, they kind of waited, and he ended up going to the hospital. And what do you think the hospital did to Mr. Parkinson's in their wisdom? Anybody have an idea? They slapped a feeding tube down him, made him MPO. Now he's allowed to come back. He's not at risk. This happened in 2010, but the reason I'm telling you this story is every time I tell it, at the end, when everybody goes, there's usually one person, I mean this year, in the last 12 months, that will come up to me and say, it's happening in my community. So the culture of diets, it is changing, but it's a slow one. It's a slow one. So I'm looking for you guys to be the pioneers to help us change. So with that, I just want to show you Mr. Parkinson's. There's Mr. Parkinson's. So the stories I just told you are to help define what culture has been, so you can better understand what culture has to become. Big question, a lot of times when we do this talk or a similar talk, it seems like folks get a little bit confused with, don't we treat them differently and recommend and talk about risks and benefits a little bit differently. Yes, Jonathan? Okay. All right. Don't we treat them different? And the answer is no. Perhaps some of the target ranges might be different, but basically at the end, the decision defaults to the resident, whether they're in long-term or rehab. So things that we're going to be talking about today really is applicable to both of those units. And then we'll describe when therapeutic diet restrictions are necessary based on the regulations and the standards. National standards, CMS requirements. Who writes the standards? Who does that? Any idea who writes our standards? Is it CMS? CMS writes our requirements, right, for participation, for Medicaid, Medicare. Professionals, it's the professionals. I know we've got some dietitians, it's Academy that would write standards, talking about speech therapy, the Speech Therapist Association would be writing standards. So it's the professionals that write the standards. And then CMS, of course, will write the requirements. We're going to focus today just on menus and diets. There's a lot of other things we could talk about, but we're going to strictly talk about the new requirements in regards to menus. New dining standards. Has everyone heard of new dining standards? I think Linda Bump from the last session asked how many are using parts of the dining standards. Show of hand. Have you guys heard of the dining standards? No? Okay. I never know how far to get into this. August 2011 they came out. It's a 66-page or 60-page document. It's free from the Pioneer Network. You can download it. There's a website there. You go to the resource library and go to the dining section. Current thinking and evidence-based research is listed. And then there's 10 recommendations, of course, of practice. This is it's the first time it came out, and it needs to be updated, so we're talking about it. It's a matter of who's going to pay for it and who's going to work on it. The dining standards originally came about because they were funded by the Rothschild Foundation, and then they got the Pioneer Network involved. And you see all these associations. They all came together, and I say this is probably better than an act of Congress. They all came together and agreed on these standards. Okay, so you see what's up there. There's I don't know how many associations from nurses, there's speech therapists, medical directors, dietitians. Most every profession that's working in long-term care had their hand in these dining standards, and in the end, they all agreed upon them. Boy, there was a lot. You can imagine in 60 pages, there was a lot of research I could have shared with you, but I chose the American Medical Directors Association, saying routine dietary restrictions are usually unnecessary and can be counterproductive. Special diets have not been shown to improve control or affect symptoms, and that was written in 2010. Another current thinking. Now, remember I told you in 1990, was it 97 or 98, the ADA position paper came out and said there's no evidence? Well, guess what, guys? In 2010, position papers eventually kind of retire, and then we have to address them again. Well, in 2010, so that was how many years later? 18 years later, almost 20 years later, they rewrote that position paper, and I swear it says the exact same thing. The exact same thing. There is still no scientific evidence that to control carbohydrate, to use carbohydrate-controlled diets are effective in long-term care. So we're still preaching the same thing. So you see, we're kind of going slow on some of this culture change stuff, aren't we, with diets? So what does CMS say about the dining standards? They support them, and they also have presented ACA surveyors. Now again, this was 7 years ago, but there's a 8-minute video, and I have the website at the end, if you're interested in that web address, that you can go on and click and watch the 8-minute video that CMS put out to train the surveyors on the new dining standards. So they're agreeing. Okay. In red, Janice is going to talk about those diets here in a minute, and so I'm not going to spend any time on that. The individual altered consistency diet. I wish we had a lot of time to talk about that, but we don't today. Has anybody heard of the word IDDIS? IDDIS, which means International Dysphagia Diet Standardization Initiative. Whew. Anybody ever heard of that? Okay. Okay. Well, you're going to hear a lot more about it. Is it a 5-year initiative? 5-year plan, I think? Listen, of all the diets that we're going to talk about today, and you'll see where the cardiac and the low sodium, the diabetes, they're going to kind of go. But I don't see where the altered consistency might be going anywhere. Unfortunately, the dysphagia treatment, the cornerstone of dysphagia treatment, is altering the texture of food or the consistency of liquid. That's the way it is today, and I have a feeling that's the way it's going to be for a while. So that diet is going to be around, so we're going to have to pull our heads together and figure out how we can honor the choices of when someone, such as Mr. Parkinson's, makes a decision, a risky decision, to refuse those restrictions. And talk about how slow culture of diets are going. 20 years ago, there was a study that showed 91% of people on mechanically altered diets were served more restricted textures than needed. That was 20 years ago. Where do you think we are now? Raise your hand, you all still use like the mechanical soft, puree? And there's not a lot in between, is there? Okay, I have some homes that use almost like 40 and 50% puree. So we're still using them quite a bit. Okay, real food first. Basically, all that's saying is I think the party's over with commercial supplements. We all know that staff convenience. We know the nurses love it. You know, right there it is on the med cart. They get to use a little 2-ounce container. They have their they can document that they consumed it, they offered it, and then they can keep on going. So it's labor saving and fairly cheap, only 2 ounces, but it's cough syrup. I mean, what do you want, milk and cookies, or do you want 2 ounces of cough syrup? So I think you're going to see, I know you're going to see, in examining the standards, real food first, and be able to justify and explain why you're not starting with real food first. Calorie-dense foods for snacks and with meals instead of commercial supplements. Honoring individual choice, we're going to go over that in a few minutes. Shifting traditional professional control to individual support of self-directed living. Okay, my story about Mario. Here is a speech therapist is pretty short, and he has a lab coat that's pretty large, and I like Mario a lot, but when I see him and think of him, I see the lab coat first. So this is a pretty good story when it comes to professional control. I was doing observation in the dining room, and this man rather loudly says, "I hate when they give me my vegetables like this." Very loud, complaining. So of course, I go over and I, "Sir, can I help you with something?" "I hate my vegetables like this." Well, they were pureed. And I said, "Well, I'll see what Mario, the speech therapist, has to say. I can't help you right this second, but I'm going to go get Mario and he'll come." So I tracked the speech therapist down, and I had the diet card in my hand, and I said, "Mr. So-and-so," and here's Mario. "I know what you're going to say. I know what you're going to say. Oh, can't do anything. I know what you're going to say. He doesn't like the diet." And I said, "No, he doesn't like his vegetables pureed." And he said, "I can't do anything. Look, Diane, he's already been to the hospital with aspiration. I can't do anything." And I said, "Mario, he doesn't want them pureed." "Oh." And it was like looking at a deer with headlights on. I mean, I literally went like this to him, and I said, "He doesn't want them." And it was like a new thing with a speech therapist. Like, he cocked his head like, "Oh, okay, well, maybe I better rethink this." Months later, this gentleman was eating potato chips. But all Mario saw, and this was just 2-3 years ago, was that professional control. He could not let him aspirate again. And it did not matter if this gentleman didn't want it. So we do have a ways to go with the professional control. And then the new negative outcome, we'll just look at Mr. Parkinson's. I believe that's really what that definition of a new negative outcome is. Okay, CMS, new regulations, best thing since sliced bread as far as I'm concerned. How many people like the new dining standards in regards to person-centered dining? Okay, that's kind of an open-ended question, isn't it? Let's talk about some of them, and then maybe I can get something out of you. Menus and nutrition adequacy. In red is what has changed. And Janice is going to talk about this and do a great job. You see where they've crossed off the dietary allowance of food and nutrition from the Board of National Research. And they say with established national guidelines. And Janice is going to talk to you about the My Plate and how that falls into that, right, Janice? Okay. Reflect, I can barely see this. Reflect based on facility responsible efforts, the religious, cultural, and ethnic needs of the resident population, as well as input received from the resident and resident groups. You see it's in red. There was no regulation that was written that said we had to really pay attention to their religious and cultural preferences. The menus need to be updated periodically. Again, that's something new. Be reviewed by the facility's dietitian. What a novel idea, huh? Or other clinically qualified nutrition professional for nutritional adequacy. And this is the best part. Number 7 is the best part of this new well, it's not new, but the number is 803. Nothing in this paragraph should be construed to limit the resident's right to make personal dietary choices. Isn't that the best thing in that regulation, number 7? Now, I'm thinking, if we have to do this, and we have to involve the resident groups and the residents, do you have forms where you have the resident council actually review the menus? Do you have a standard form that you ask those questions to, and or to the individual resident? I've seen the food preference form the same in 1982, 1992, 2002, and 2012 in a lot of communities, and it just basically says, do you like fish and liver type of thing. Now, with these new regulations, we're going to have to dig a lot further than just do you like liver or do you like fish, right? Okay, we're still on 804, and you see they added drink. So now it says food and drink. And then what they added was food and drink that is palatable, attractive, and at a safe and appetizing temperature. Safe and appetizing temperature. I can see where we might get in trouble over that one. Anyone have an idea of what an appetizing temperature might be for you, but maybe not for you? Men, I think, now I'm generalizing, men kind of, to me, will have their foods a little bit cooler than women. I like mine hot, hot, hot. My coffee hot, hot, hot. Right out of the pot. I'll put it in the microwave first. I like it hot. My husband likes his lukewarm. He'll let the coffee sit there for quite a while, and it'll be more like room temperature. So we have to pay attention to the individual needs on that one, don't we, on what is appetizing. And then for F806, again, they've added food and drink. And then the tone of the words that these requirements are using. If you notice, they crossed off on number 4 under the very last one there, F806. Do you see that substitutes offered of similar nutritional value to residents who refuse food served? So they're saying the resident refused it, and you have to offer something of equal value. It was kind of an either or, take this or take that. But now you see how they write, food that accommodates residents' allergies, intolerance, and preferences, appealing options of similar nutritive value. To residents who choose not to eat food, and that is initially served, or who request a different meal choice. You see the wording, how it's a little bit different, not quite so institutional. And then drinks, including water and other liquids, consistent with residents' needs and preferences and sufficient to maintain resident hydration. So those are what's new in the requirements for food and nutrition. Yes, Jonathan?
Sorry, I know a lot of the people in here are probably dietitians, and I guess I'm a little confused. I constantly see that everybody is so worried and panicked about, are we giving them enough? Are we giving them enough? I mean, I used to watch my grandmother eat. She'd like eat a grape and a half piece of toast for lunch. But we're worried about giving them 3 full meals a day. And I don't understand that. And the state comes and weighs your food. If they're not losing weight, who cares? We're preaching, let them eat what they want. I mean, we can always offer to educate. But I don't, it seems like we're so hung up on 3 nutritionally sound meals a day. And I don't know how many people in this room can say, oh, I eat breakfast, lunch, and dinner. For breakfast, I eat whatever, egg whites, and I don't get it. Why is it
Everybody can hear Jonathan's voice. I know he's got.
I'm a little shy, I know that.
And it's an excellent question. And the menus, the way they're written, and if you look at the food labels from what you and I buy on food ingredients, they always go by 2,000 calorie ADA. Am I right, Janice? Pretty much a 2,000. And the menus that are written from these larger food vendors are usually 2,400 calories at least. So we know that the menus for the average American needs to be somewhere 2,000, 2,400 calories. But that's what we get when we put everybody in one box. Because that's what we have to have available, and there might be a couple of folks, or depending on the population that you're serving, there might be quite a number of large men that really do need the 2,000 calories a day, 2,200, 2,400. But the majority of these little women that are 80 and 90 years old and weigh 90 pounds, how many calories do they need, guys? The dietitian don't answer, but how many calories do they require? It's not 2,000 or 2,400. It's about half of that. I mean, Jonathan's right. I just took care of my mother for months who passed away in April. And I mean, on a good day, 800 calories, 1,000. So it's true, we have a lot of plate waste because we're giving way too large of portions. We have to individualize. All you have to do is observe, ask, find out if they want small portions, and then document that and just give small portions. That's all you have to do. You're not going to get in trouble over that. Well, what about, I mean, I don't know, someone help Jonathan with, I mean, my suggestion might be upon admission, when they come in, you explain, you've got regular portions, you've got small portions, and see if you can't get them to say, oh my goodness, let's just start with small portions, and I mean, just have that as a kind of a protocol there, and of course you'd have to educate your staff on, you know, what a half portion or a small portion exactly is, how many ounces versus a regular, but a regular portion has to match what your menu is saying and what your standardized recipes are saying. But that doesn't mean you have to serve that to 100% of the people there. You could serve it to 10% of the people if that's all that's needing those kind of portions and that kind of calories. You want to say anything on that, Janice, at all, or? It's a good topic. I'm sorry. I caught you, didn't I? I'm sorry. I know. We've got to keep going. She's looking at her clock here. So, Jonathan, I don't know whether that helped or not, but I mean, we need to assess them as they come in and talk to them about how much they're going to eat. And for God's sake, quit overwhelming people with twice the amount of calories that they need and save your money. Okay, we're not going to have time at all, really, but this is your International Dysphagia Diet Standardization Initiative. I'm excited about this because it's actually making consistencies in the diet textures. I remember years ago when a surveyor asked me, and we had chopped meat, and they come into the kitchen, and where's the dietitian, and okay, and then I looked at her like she had, I think, 4 heads, because she said, explain to me what diced is. I mean, what's diced? How many, you know, like, you mean what size is the particles? Yes. I'm like, I don't know, we just dice it. But now, with the standardization, they have it down, I think it's 1/2 centimeter for the minced. I mean, they've got these portions down in terms of minced, moist meat. Let's see, they've got minced and moist. They have small and bite size. For the thick and liquids, it'll be slightly thick, mildly thick, moderately thick, and extremely thick. It's kind of interesting. They have a straw, and you put the liquid, you put your hand over the tip of the syringe, you put 10 mLs of liquid in that syringe, and then you put let go of your finger, and if all the liquid comes down off of that syringe in 10 seconds, that's a thin liquid. If you get 3 or 4 drops left over in that syringe in 10 seconds, then that's probably a slightly thickened. If you have, up to 8, 10 drops left in that syringe after 10 seconds, that's probably a little thicker liquid. So I know I'm giving you a lot, probably too much, but they have perfected the consistency of the liquids and the food textures, and you're going to hear a whole lot more about it. And I think that's good because I think we're going to have more of a choice between just regular, maybe ground meat and puree. We're going to have something in between. A lot of them have the dentition problems, and I really do think they need just minced and moist, not that yucky puree stuff. I think a lot of them will benefit from a minced and moist. Okay, therapeutic diets, I'm going to keep on going. Now, the federal government says licensed dietitians can prescribe diets. A number of states have been saying that for years, but now the federal government also has given permission for dietitians to write orders. Okay, in a nutshell, that's ITSE. Their website is absolutely phenomenal, a lot of training products. They're doing a fantastic job. So, and I believe the slide has the ITSE website at the end here if you're interested in that. The Dining Standard Toolkit, that's for a price at the Pioneer Network store, and that's loaded with all kinds of resources, forms, and things like that to support the dining standards. The care planning, this is free, also on the Pioneer Network under their resource library. This is a 30-page document, had a lot of, I think 51 stakeholders came together and agreed upon this type of care planning, which was meant for risk charting when people make risky decisions. CMS was part of it. Like I said, 51 stakeholders, lots and lots of medical director, the academy, I believe, all kinds of stakeholders are involved with that care planning. The inside scoop, if you put your cards in the back, I'm going to draw. I'm proud to say I've written a manual and dedicated it to Mr. Parkinson's. Through the process of what happened to Mr. Parkinson's, I realized what they did to him was because they didn't know what they didn't know. They didn't know and have the tools that Mr. Parkinson's needed to be able to live the life and have the liquids that he wanted. So this manual is loaded with forms. You have I'm going to try to change slides with my cell phone there. Loaded with forms that we needed in 2010 and did not have. Okay, so don't miss a step. There are, and you cannot read this, but 7 steps for when someone makes a risky decision. And I'm going to go through those steps very quickly. First of all, make sure they know when they come into your community what their rights are. I think sometimes we don't do that. Make sure the staff knows what the residents' rights are as well. So that's a little declaration of dining independence. It's part of the whole process. Dining preferences, I already mentioned to you. We've got to ask them more than if they like liver and fish. So here's a dining preference form that really talks more intimately about getting to know the resident routine. Inform the person of risk, benefits, and options. Don't forget, we have to tell them the risks of going on puree and thickened liquids, don't we? Not just the risks if they don't go on it, but risks if they do, or benefits if they don't follow the restrictions. There's benefits and risks on both sides, aren't there? Okay. Find out what matters to the resident. And I'm sorry, I didn't get your name, but you spoke down here earlier and you said it wasn't a legal document, but we found out what they wanted. I kind of disagree a little bit. I think quoting someone on what they want, I wish they would have quoted Mr. Parkinson's. He would have told them, I don't really care so much about the puree food you're giving me, but I want thin ice water, and I don't care if I choke. And if they could have quoted him on that, that's very, very powerful. Find out what matters to the person first. And then we've got a long ways to go with the alternatives and approaches. I'm so tired of the canned approaches that we're using. It's not going to work when we try to individualize diets. It's not going to work. And I don't have time, but I had a lot of different alternatives that I've thought of in the last 8 years that we could have done for Mr. Parkinson's that we didn't. Prevail cups, we could have metered his liquid. We could have seen if maybe he didn't want ice cold, thick, maybe fruit-infused water. We could have tried a lot of different things with him, but we did not. Okay, so, and if your community or where you're working doesn't have tip sheets, to make sure you inform both the resident and the staff of the different risks that might be involved if someone's made a risky decision. Do they know how to manage these risks and mitigate the risks? Are they educated on that? And then last but not least, you have to step back and make sure that and monitor that they are happy with the decision and your approaches and that it is working. Those in green, and I know you can't see this dining satisfaction form, but if you haven't heard of the artifacts of change, go to the Pioneer Network. I think it's the very first section you see under the resource library, Artifacts of Change. It really tries to quantify, are you in your culture journey? And some of the questions that they're asking here are things like, is it important to you that you can select foods at the time you're being served? Or here's another one. Is there a special dining room, not the main dining area, but a special room available for you and your family to use for special gatherings? Those type of things, they're not requirements, they're not regulations, but they're measurements of how far you're coming with your journey. So culture change of diets, honoring individualized choices, that's bottom line of the culture. And that's pretty much it. I mean, we have to do all of these things. Collaborate with learning circles you've heard of, managing the risk, obtain preferences, pay attention to menu choices, decision-making, satisfaction surveys. All of that has to do with the culture of diets. Any questions for me? And here are the Pioneer Network standards, the website. Here is that CMS video for the surveyors regarding the dining standards. I almost said new dining standards, but they are from 2011, so they're not really new at this point. Any questions? Okay, I'm going to hand this over to Janice, and I think she's going to knock your socks off when she starts talking about the diabetic diets and the low-fat diets. So I know you'll do a better job than I did on that remote. Do you want this? Or do you want this?
I'll use this one too. Hi, my name is Janice Raymond. I have been involved with the Pioneer Network now for 6 years, I guess, 7 years. And I'm going to tell you a little bit about my background, because we have to introduce ourselves so you know why I'm here speaking, because I am a bit caught between two worlds. I've been in long-term care a long time. I am a proponent of the dining standards, have adopted the dining standards, have really appreciated everything Pioneer Network does. But I am also, in addition to my job as clinical nutrition manager for Thomas Cuisine, which is the contract food service at Providence, Mount St. Vincent, and I'll tell you a little bit more about that later. In addition to that, I'm the editor of a textbook. Some of the dietitians might know the Krause Food and the Nutrition Process. Anybody use that in there? Oh, yay, some people have used it. It's been around for 60 years. I haven't done it for that long, but and it's the textbook that defines therapeutic diets. It's used to teach mainly dietitians what a therapeutic diet is. So I edit that textbook, so like I said, caught between two worlds. And my passion has always been around cardiac diets, heart-healthy diets, which started way back, another bit of my history, and you'll know how old I am. My very first job was with cardiac surgeons at the University of Utah, where I was privileged to work with the artificial heart team that implanted the very first plastic artificial heart. Some of you old enough might remember the patient, Barney Clark. I was his dietitian, so he had cardiomyopathy. So that started my interest in cardiac. I've worked in a cardiac ICU, and I've worked in a heart failure clinic, which I learned a lot talking to people with end-stage heart failure. So a little bit about my background. I'm also certified in geriatrics through the Academy of Nutrition and Dietetics. And lastly, I do want you to know this, the Academy of Nutrition and Dietetics, 77,000 dietitians, they have appointed me as a liaison to the Pioneer Network because they feel it's so important for these two groups to work together. And so that's my job, is to stay in communication with the Pioneer Network, and hopefully we'll work on that next round of dining standards. Okay, so with that said, So I was surprised, how many of you have rehab in your buildings? Oh, good, okay, a few of you, because I didn't feel like I heard people say there was a difference. I mean, to me, there's a dramatic difference between rehab and long-term care, because when you come to long-term care, you've come to live there. This is your new home, and the goal is for you to be comfortable and to have purpose in life and to have activities you care about and food you enjoy, right? And you're staying there. But rehab, the goal is to get you out of there as fast as you can and as well as you can, right? Uh-huh. Okay, well, I'm not talking about nutrition at this point. I'm talking about the goal of their purpose in that building is to get better and go home. Most of them don't want to stay there. So that's what I mean. The goal of food, yeah, well, we'll get to that. But the overall goal, any of you that have to sit in those Medicare meetings, is are they progressing? Are they getting better? How many Medicare days do they have left? And when can they go home? So for that reason, we have to acknowledge a little bit of a difference in what we do, because we're all preaching to the choir here. We've all bought into this. Many of the providers that we deal with and many of the nurses that we deal with, they haven't yet. And in their great desire to take the best care of people, and I really believe that, they still think that taking good care of someone means putting them on some specific kind of diet that matches their disease state. So what I want to do is try to help you go back and have the conversations with some of those people who aren't on our bandwagon. And there's still a lot of them that I see out there. I meet a lot of dietitians who aren't on our bandwagon, but a lot of physicians and nurses that still think there's a diabetic diet and still think that we shouldn't be giving patients eggs or whatever. So let's start with the two most common diets that people come in from the hospital on. What do you think? All right, cardiac or heart healthy and diabetic. Yeah, that's what I see. That's not scientific, that's just what I see. It sounds like it's what you see as well. And is there a reason for that? Certainly is. It's still the #1 killer in the United States. There's a little typo in there. That's 81 million adult Americans. I think a zero got left off. 1 in 3 people in this country have cardiovascular disease. 1 in 3. It's pretty big. It remains the #1 killer of men, women, the #1 killer of people over age 65, the #1 killer of people with cancer. It's still the #1 killer. We certainly see a lot of people come into our rehab facility that is either for our rehab floor, I should say, that have had open heart surgery or stents or an CHF exacerbation or on and on, different cardiac diagnoses. So this is the one that you're most likely going to see that diet for. I have to step out here because I'm too short to see over this thing to that. Okay, so what are we talking about with I'm going to talk to you about what the big guidelines are for the cardiac. What is the most up-to-date information for guidelines? And they're divided a little bit by what kind of cardiovascular disease you have. So there's atherosclerotic disease, which is a clog of some kind, hypertension, high blood pressure, ischemic heart disease, which means not enough oxygen getting to the heart, Peripheral vascular disease, it's another one you see in a lot of charts. So people whose circulation isn't what it should be because their heart isn't working the way it should. And heart failure, which is basically the end result of other kinds of heart disease. So what are the guidelines? What are the most current guidelines? And I'm telling you that most of the people I talk to that don't come to Pioneer meetings and don't go to a lot of conferences, they are, and we've had this conversation, 10 years behind the time. If we're lucky, they're maybe 20 years behind in what they believe the recommendations actually are. So I'm going to try to give you the information to go back with, and maybe for your families as well. So there's various guidelines. One is the U.S. Dietary Guidelines. The most recent one was in 2015. A new one is due to come out in 2020, I believe. Your tax dollars, hard at work. We'll talk more about that. The American Heart Association, in conjunction with the American College of Cardiologists, is the AHA-ACC. The AHA-ACCF is the guidelines for heart failure in conjunction with the American Heart Association. And these are the primary guidelines that are out there that physicians are looking at because they have guidelines far behind diet. They also tell you, what drugs people should be on and how to manage their blood pressure and their lipids and all that. So starting with the USDA. So it's so simple. This is based on the U.S. Dietary Guidelines that are developed by scientists for the purpose of setting policy. And like I said, it's your tax dollars, so you should be interested in what they're for. This replaced the pyramid. Do you remember that pyramid? It was a simple one, and then it was a complicated one, and then they went super simple with the plate. And so what the U.S. Dietary Guidelines, which is used for previously would have been used in a long-term care setting, but it is used in schools and older Americans congregate community sites, Meals on Wheels, those programs covered under the Older Americans Act. They are used for that, to develop a balanced meal. They're used in the armed services and in the VA, so they are used pretty widely. What it says is half your plate should be fruits and vegetables. Pretty simple. And I actually use this a lot. People respond pretty well to it because it's simple. So quarter of your plate protein, or we always say your protein should be the size of your fist, not 16 ounces steak. And low-fat dairy. That doesn't say low-fat, but it's in the guidelines. Oops, did I do it now? No, okay. So the American Heart Association, American College of Cardiologists, came out with a lifestyle management guide that has the recommendations for the diet you should have for prevention and treatment of heart disease. This came out in 2014, I think. Did I have it on there? I think it's 2014. So what does it say? Because this is all the researchers that get together and they pull all the research and they say, what is the evidence for what diet is actually going to help with heart disease? And what do they say? Fruits and vegetables, right? Lots of fruits and vegetables, not too much red meat, lean poultry instead of red meat, lots of fish, more legumes, beans, that kind of thing, whole grains, increased fiber. So those are all the general guidelines. In addition to watching calories, that's always in there. So that's the American College of Cardiology part of it that's aimed at lipid management, which is more aimed at that atherosclerotic disease. But they also have a guideline for hypertension. What does the one for hypertension say? It's the same thing. I'm not going to read it all to you. It's the same stuff. Fruits and vegetables, not too much red meat. The whole foods, yada, yada, not too much processed. But what they say at the end is there's 3 diets that they will recommend to meet these guidelines. These are the actual diets. So it's the USDA that I just showed you, the general one that's used for overall menu planning for all kinds of stuff, the DASH diet, and a Mediterranean diet pattern. So the DASH diet, by the way, is an acronym that means Diet to Stop Hypertension. Anybody see this article? It hit all the news. It was on all of the, and it was getting sent around Facebook and whatever. Okay, so the best diets in America, the rankings, I don't know how US News and World gets to do this, but they do it every year. And they named the DASH diet as the #1 best diet, overall diet, for being healthy, for watching your weight, for healthy heart, for everything. So this is probably, if we really wanted to be on the healthiest diet, the diet we should all be on. So what is, it's been around for a while. It was really promoted by the Dairy Council, so they've spent a lot of money to promote it because it includes low-fat dairy. So what is it? It's the same old thing. It's lots of fruits and vegetables, very little red meat, a little bit of fish, much more vegetarian protein, low in sodium, high in fiber. It's pretty much the same thing. It is defined by specific servings, though, of how many of each thing you need, and it's a lot. So it suggests capping sodium at 2,300 milligrams, and we're going to talk a little bit more about sodium. I know chefs just love when we bring up the sodium. 2,300. In some of the DASH diets, if you have serious heart disease, they've taken down to 1,500, which is not realistic. And I think that 1,500 is going to change. I think that research hasn't quite caught up. So how does the DASH diet relate to the Mediterranean diet? Probably you've heard about the Mediterranean diet because there's been a ton of research saying not only is this the best diet for your heart, what else have you heard it's good for? Alzheimer's, yes. The brain diet and the mind diet, it's all variations of this Mediterranean diet. Anything else? It's also an anti-inflammatory diet, if you've heard that term. So pretty much any chronic disease related to inflammation, of which there are many, they come back to this Mediterranean diet. So it's important to know exactly what it is, because remember now the Heart Association is recommending it. And so is most every other organization involved with some sort of disease state, to be honest. So what is it? The Mediterranean diet is actually, it's not defined by how many servings a day. It's a group of countries in an area that all share some similar diet patterns, and those similar diet patterns are kind of the same old thing you're going to hear over and over. So those countries that surround the Mediterranean tend to have diets that are higher in fish, they're on the sea, high in non-tropical oils like olive oil, nut oil, that's part of this, and eat a lot of nuts. That's some of the non-meat protein that's recommended. Some of them eat a lot of non-fat dairy, mostly in the form of yogurt. Some of them don't. So it's a pattern it's not an actual diet, it's a pattern of how people eat that's become of great interest to many people studying diet. It's also become a challenge when you try to do research comparing what's better, the DASH diet, the MyPlate, the Mediterranean. So for that reason, you'll see the recommendation from these organizations being the DASH diet rather than the Mediterranean, because the Mediterranean, like I said, it's a diet pattern. And so when you put literature together, when you try to do big studies that put literature together that's all on the same topic, they call meta-analysis, it's really hard to do if the diets are too much different. They can't do it. And because the Mediterranean diet wasn't well defined, it's been a challenge to do meta-analysis. So there was this article I just thought was interesting that did in fact define it. I think I've got to read it because I can't remember. It defined it as 3 to 9 servings of vegetables, a half to 2 servings of fruit, 13 cereals, 8 servings of olive oil. It's 37% fat, of which only 9% is saturated fat. So it's pretty low in saturated fat. That means there's not much meat when it's that low. 33 grams of fiber. So I think we're starting in the research world to get around to kind of defining this Mediterranean diet so that we can better find out what specific diet might help a disease, prevent it or treat it. So when somebody comes in from the hospital and they're on a cardiac diet, what does that mean? In the old days, what that meant was no eggs, margarine instead of butter. What else? No fried foods, yeah. A lot of chicken breasts. So it used to be more defined that way. Really what it should be now, what I'm proposing to you, is that it should just be that same diet that's recommended for all of us to eat to be healthy, which is the USDA, My Plate. It's all the same diet. So it should no way be looked at as a diet restriction. Those are the choices. And I'm still all about choice. But I'm going to talk to you about how we implemented a way to give those people who come into our rehab, who are, some of them younger than me, that really do want to be on some kind of a heart-healthy diet. It's what they eat at home, and they're trying to heal, or we have the vegetarians who are just trying to be healthy. There are those people more often in rehab, but we've had a couple in long-term care as well, who do want this kind of a pattern. It's a pattern, it's a menu option, it's not a diet restriction. Diet is a bad word. Okay, so this is what the Mediterranean diet is not. Yes, Italy is on the Mediterranean, but it is not the kind of Italian food we've gotten used to in the United States. That's lasagna with a lot of cheese, and spaghetti and meatballs, and or I could pick on Greek food too. It's not, a big hunk of lamb. That's not what it is. It's more choices like this. And this really opens up a lot of choices for people. And a lot of these choices, fortunately, are easy to chew. And remember, we're also supposed to be, with the new Medicare guidelines or CMS guidelines, we're supposed to be offering people culturally appropriate things. And cultural isn't just about your geographic background or your cultural background, it's just about how you usually eat. So when people come in and say, well, I usually eat pretty healthy, I usually try to not eat a lot of meat, we need to be able to meet that. So I feel like our Heart Healthy menu does that. So these are the kind of things we incorporated into it. More legumes, more fruits, more that's yogurt on the bottom, because most of the Mediterranean diets have some kind of fermented food as part of it. Nuts, in some way, more nuts. We don't have red wine, but red wine is in there. I just needed to be sure you all saw that. It is in that healthy eating guide. So this is how we went about doing, how our transition was from old-style cardiac diabetic diets to where we are now. Because it's been a journey. It's been a timeline, certainly. So I thought it might be helpful to share. I have to keep drinking here. This is very dry compared to Seattle and compared to Florida. Okay, so I work at Providence, Mount St. Vincent. Were any of you at the Pioneer Network a few years ago that was in Bellevue? Anybody? Bellevue, Washington, Seattle area? No? Okay. Because a whole lot of people came over. One of the intensives was to come and visit our community and learn about, our setup is to have neighborhood kitchens. We have 8 neighborhood kitchens, including in the rehab, which we call transitional care. So no, from a nutrition or meal standpoint, we don't treat them differently. But it's an old building, middle of the city, and we serve about 1,200 meals. Is that right? That seems low. 16, okay. 1,600 meals a day. So it's fairly complex. We have assisted living. In our assisted living, they can go to a dining room, sit down, dining room, or they can go to the cafeteria. We have the neighborhoods, including a whole building with sisters, and they have their own dining room over there, but everybody can go wherever they want to eat. So we have long-term care people that come down to the cafeteria, some of the sisters that come over to the coffee shop. We have people moving all around. So it's kind of complicated for food service. So some considerations when we were planning what we were going to do. So the Pioneer Dining Standards, I remember I took the job there in early 2010, and one of the first things that happened, because what you don't know is our administrator was one of the founding members of this organization. So one of the first things that happened is I got handed the Pioneer Dining Standards that they were just coming out. I think I even had the pre-press version. It's like, we need you to do this. Okay. So that was very much a part of what we kept in mind as we developed things. Thomas Cuisine Management is a contract food service company that works within all the Providence senior buildings. So Thomas is a regional, well, I guess they're national now, but they're headquartered in Boise, Idaho. And their philosophy is very much about whole foods, real foods, food from scratch, not using pre-made stuff. So that was perfect, because that just fell right into the same philosophy of the Pioneer standards and where we wanted to go. But we had to consider, as we're looking at this, trying to implement this in all these different areas, we had to think about, we do have elderly people with taste changes. Sometimes they need more moisture in their food. We go through that a lot. So sometimes digestive changes. We definitely have people that have, if you suggest eating beans, they will tell you that they just can't eat too many of those for digestive reasons. As we age, unfortunately, our digestion tends to slow down a little bit. And chewing and swallowing problems, especially texture problems, but chewing too is an issue. And a lot of the foods I just talked about take a lot of chewing. So we wanted to be sure when we developed a menu that we had enough foods for all those different considerations. Whoa, what happened to it? Oh, wasn't supposed to do that. Okay, it's got an animation I didn't know. Okay, I'll just go through the timeline. So originally we had all those crazy diets that everybody else has. We had cardiac, and we had a renal, and we had a consistent carbohydrate, and all that stuff when I first got there. So on the timeline, the My Plate came out and the Pioneer Dining Standards came out. And then we decided we would start looking at what the guidelines, the most current guidelines were. And so the new American Heart Guidelines came out about that time. And then we decided we would make an effort to get rid of all the therapeutic diets. So we actually got rid of virtually all of them in 2012, which was a big challenge. I'm sure many of you have done that, where overnight you have to change every diet card and do a lot of education. We got rid of everything but cardiac at that point. We did keep cardiac, mainly because of our rehab building and because I just had a lot of pushback from our providers. 1 in 3 people die, people go back to the hospital with fluid overload, lots of reasons there was a lot of pushback. So we kept that cardiac, but we also kept our philosophy of people can have the choice of what they want. And I'm telling you, I got so tired of having, and we couldn't write diet orders at that time. I spent so much time talking to doctors and saying, please change this diet order because this person does not want this diet. They're not going to eat this diet. Because we had, it was restricted. You had a lower amount of meat and lower amount of carbohydrate, all those things that we're supposed to do, and they didn't want it. Most of the people in rehab didn't want it, but definitely most of the people in long-term care didn't want it. So we always gave them the choice. We'd go talk to them, and they'd say no, so then you'd have to find the provider, change the diet. And so after we did this for a while, I said, okay, this is crazy. Why are we doing this? And we said, let's think about this differently. And because I'd been writing a book chapter and kind of going around the country speaking on heart disease, I had an aha moment of like, wait, this should just be a menu option. This isn't a diet, it should be a menu option. So people can decide to have it or decide not to have it, but we'd have it available, so when somebody wants that so-called heart-healthy menu, it would be there. So that's what we did. We created a heart-healthy menu rather than a cardiac diet. And they do fall in different categories for survey. It's just a menu option. It's not a therapeutic diet. So how did we go about doing that? Let me check my time here. Oh, God, I'm doing okay. So we did a lot of education. We had a lot of conversations with the providers. And you know what? This is a trick I'm going to give to all of you. The best thing you can do is have your chefs create something outstanding off this menu and bring it to them to eat. That's what I did. I brought them our hummus plate with all the vegetables, and they bought in. Because you know what? All of them at the table are trying to eat healthy. All of those providers, they're all kind of on the heart-healthy diet themselves, and they loved it. So I felt like they listened in a different way. So I convinced them that we're going to go to this menu option, and I showed them the menu and let them taste some stuff. Showed them that we did have options for people. Like hummus is great for people that can't chew very well. Talked to the residents, had the residents try some of the menu items as well, and did a lot of education. So it's a totally separate menu. So we have just our standard menu that has, a couple of options every day, plus a whole bunch of always available. And then we have a heart-healthy menu. It looks like you get something in a restaurant. I'll show you another picture of it. And it's, like I said, it's a good option for other than heart disease, people that are trying to cut calories, that's our first go-to, people with diabetes, which I'll talk a little bit more in a minute, and people that are just foodies or vegetarians. That we use it a lot for that, honestly. Do you get many vegetarians? Or people that don't want to eat as much meat, even if not total vegetarians, but yeah. Okay. And I think that's going to grow. I think that's that, when we talk about that new generation of slightly younger people, I think that's what we're going to see happen. So our menu is designed to be higher in omega-3, which just means it's higher in fish. It's got fish options every day. It's one menu. It's a static menu, but it has a lot of choices. More vegetarian protein, so it's got a tofu rice bowl. And when I've had people come in that are vegetarians, they're pretty excited about that. It's higher in fiber, for sure, because it's more fruits and vegetables. Our rice bowl has brown rice. Brown rice is the go-to item on the Heart Healthy. Can they have white rice? Of course they can, but the Heart Healthy is presented with brown rice. It's got more phytonutrients because of more fruits and vegetables. It is lower in sodium. It's definitely lower in sugar. Now that is important to remember. It is lower in sugar. The heart guidelines, the Heart Healthy AHA, ACC guidelines are for low sugar. Everybody keeps talking about carbohydrate, but the one thing really spelled out in there is low sugar. It's low in processed ingredients. There's no bacon on it. The bacon is always the biggest issue. Is that like regional, or does everyone have the bacon thing going on? The bacon thing going on, okay. So when I presented it to the physicians, I remember they said, "What are you going to do about bacon?" I said, "Well, I think it would still be better if they were on the Heart Healthy menu, but we said go ahead and have bacon. It's still better than not being on the Heart Healthy menu with bacon." And they said, "Oh, okay, yeah, that makes sense." They were even worried about people getting their bacon because they probably get complaints. So it's not spelled out on there, but it's available. It's lower in red meat. It has more chicken, more fish, more more non-meat options. So the heart healthy shift, it doesn't have to be, you can do it kind of one thing at a time. I just want to encourage you to can take small bites, and we certainly took small bites when we did it. So one of the first things to me you have to worry about, and this is true of the whole, my plate, anything we're looking at to try to meet some kind of healthy food guidelines, is to get those high sodium soup bases and gravy mixes out, which homemade is a whole lot better, but that just bumps up the sodium on everything. So that was one of the first things we had to do, was to get rid of the sodium, the high sodium bases. Fairly easy to just start adding more spices and herbs, especially if you have a skilled cook. Some of our residents questioned at first, what's this taste in here? I'd have them say, you know what, I don't understand what this is. And so I'd tell them, oh, they put rosemary in the chicken or whatever. And most of them were like, oh, okay. They just needed to know what it was. They weren't it wasn't that they were completely unopen to a new taste. They just kind of wanted to know what it was. So like I said, back to lots of education. Vegetarian sources of protein, which sometimes people with chewing problems really prefer, the hummus and the tofu. And one of the last things we actually changed, and we didn't change it 100%, was to start making homemade salad dressings, because salad dressings are tough. They're pretty high in salt, and most of them have a lot of processed stuff in them. So we make a couple of them homemade now, not everything, but at least we have the option. And there's a lot of people who they really want their Kraft, whatever, anyway. So they have those options. But you can start smaller, because remember, these are just options, and add it. I know not everybody has a big food service, not everybody has really skilled chefs. We all have different things we have to stick to in terms of cost of food, so you can do it. Yeah. So this is our heart healthy menu. We have a separate order form that people use. Yes, they do have to circle it. Was that you that said you don't want to circle menus? This is our other one you don't, but this one we do have to circle a menu choice. So you can see breakfast, it's a static breakfast. We have homemade granola that they can have with yogurt. That's a popular thing, especially when we have fresh fruit. We have rice bowls that have been, in fact, I have pictures. I should get to the pictures. Yeah, there's the pictures. And, these are very, very amateur pictures, but kind of gets the idea across. So we have 3 different rice bowls that you see. That upper left is I think that's the salmon, or is it, we have a salmon one and a chicken one. We have 2 different kinds of sauce they can pick. They can also just choose to have Asian if they want. Yes, that's high in sodium, so we just tell them, but yes, they can have it. We have salmon available every day. This is Seattle, remember, so it's kind of a cultural thing there, but it's really popular. They can have a salmon burger, or they can have a salmon fillet. We've been using different kinds of grains. I think that's our, what is that? Is it lentils, or is it I think it's the lentils, yeah. It's a lentil pilaf. And up in the right corner, we have they're little yogurt parfaits that have our homemade granola. So it wasn't super labor intensive, I guess what I want to get across. The bowls were pretty easy for the chefs to manage, because you just had to have the rice available. We already have vegetables. We always have vegetables. We always have chicken. We always have salmon. We always have the tofu. So as long as they order it ahead, now this is one that's a little harder to take to the table and offer it. We do have to order it ahead, but it's been fairly easy to manage. And then we have an always available menu that a lot of the stuff's on anyway, like our salmon burger. So we just drew from our other menus what we knew would stand up to heart healthy. So I didn't make a copy, but it's in the app, the education that we give out with the menu. When we bring the menu to someone and talk to them about whether they'd like to have this as a menu option, we have an education piece on what I've been telling you. What's heart healthy? Why are certain foods on here? Why do we have more dark greens? Why do we have brown rice instead of white rice? That kind of stuff. It's just a one page. And what we found is really important is to have a glossary. so that people would, because legumes is not always understood, and it's a hard thing to, otherwise you have to list a bunch of foods. So omega-3 fats, monounsaturated fat, phytochemicals. So we have a little glossary to explain to people. Is there anyone who can't go on this? Dietitian, some of you could probably guess who's not appropriate for it. Not many, but Reno. Okay, so if you have somebody with kidney disease who has to restrict their potassium, which not all of them do, again, that's an individual diet, but if you have someone for some reason has to restrict their potassium, you have to be a little careful because potassium's in fruits and vegetables, so, and beans. So that's a challenge. Anything else? So the chewing, you don't have to, they can eat some of the things on here. They can't eat all of them. It's got a lot of salads. So if it's somebody has significant chewing problems, I have to direct them. Do something? I don't think I did. Is this one working? Okay, I'll just switch. I'm flexible. All right, switch to this one. So those are the two groups that I would say maybe aren't appropriate for the diet. So, but who are some of the others that can benefit? All right, so let's talk about diabetes. We talked about heart disease. Let's talk about diabetes, the other big one we get all the time. And yes, we still get those. NCS, if people in the room didn't know what that is, it's no concentrated sweets. It was the silliest diet and it was rampant. And it still shows up. And what does that mean? It's that somebody's having a birthday, can't have cake. No, that's crazy. Oh, you bring me another one. Okay, is that one working? Oh, great, wow. This is great service, thanks. Then I can see better, so I don't miss something. So the fact is there is not a diabetic diet. There is not. And when they order a diabetic diet, it's complete nonsense. They might as well be ordering the Green Martian diet because there is no such thing. Years ago, there was something called an ADA diet, and it had a calorie level, and that was 20 years ago? Maybe? Yeah. So people, it amazes me that the hospitals still perpetuate this because the American Diabetes Association is quite clear. And their research shows the best thing you can do for someone with diabetes is have them meet with a dietitian and individually figure out what they need in their diet if you're going to have a diet. There's no across-the-board anything to do with controlling carbohydrates, or the only thing they will say is it is advantageous to not drink sweetened beverages and juice. That's it. Otherwise, they say, meet with a dietitian, figure it out individually. So my favorite thing is when doctors come to me and say, this person needs to be on a diabetic diet. Because I always say, oh, okay, what is that? Do tell me what it is. And they're always like, well, I don't know, they shouldn't eat sugar. It's like, well, it's the Diabetes Association actually doesn't say that. Well, you should control their carbohydrate. Well, how? Like, what carbohydrate when? Anyway, we go back and forth, and then they usually just go, I don't know, do whatever you want. So I encourage you to go back when you see those being ordered and try to educate. Have them look at the Diabetes Association guidelines. They really, it was hard for a lot of dietitians to take, and I think some of them still are having trouble with this, but really controlling blood sugar is now much more about your insulin or whatever your medication, if it's oral, adjusting those medications to your lifestyle. Now, if you have type 1 diabetes and you have an insulin pump, that's a different story. Those are not, we occasionally see them. They do need to count their carbohydrates because they're dosing their insulin. But for the kind of people we see, especially elderly people, long-term care, absolutely every guideline says do not restrict their diet. Nothing's ever been shown to help in any way by restricting their diet, and it's probably going to cause more harm. Mm-hmm.
Sure. This is the 2016 Diabetes Care, the American Diabetes Position Paper. When determining glycemic control goals for older adults, the risk of hypoglycemia is the most important factor. True or false? The answer is true. So this was just 2016, the Diabetes Association is saying there's more danger in hypo than there is hyper. I'm sorry.
No, that's true. Yeah, low blood sugar, especially if someone's on insulin. But, and there are different standards for people that are elderly. The things we guide us in managing someone with diabetes is their hemoglobin A1C and their blood sugar levels. They're all acceptable at higher levels when somebody is 85 or 90 years old. So what should we do for somebody with diabetes? What makes sense? Not to restrict them, certainly, but again, we get some of those younger people, and they are concerned about trying to stay healthy, trying to minimize the complications of diabetes. And what does the Diabetes Association say? It says Mediterranean diet. That's their recommendation too. Mediterranean diet pattern, no sugared beverages. Does it recommend using sugar-free desserts and sugar substitutes? No, it doesn't. It doesn't. We don't need sugar-free pudding and sugar-free Jell-O. It's not recommended, and it doesn't taste as good. So, and the food service, people love it when you can say, yeah, get rid of all that. Let's just have regular pudding and regular cake. So, people with diabetes, however, do die of heart disease. That's the main thing. People don't usually die of diabetes, they die of heart disease. So there's a whole position paper from the Diabetes Association on taking care of your heart. It's not just about diet, it's about a lot of other things. But their message in 2015 was, please, people with diabetes, pay attention to your heart, because that's really what's going to kill you. So it's all the same diet. That's my message I hope I'm getting across, is it's really all the same diet. It's about eating more fruits and vegetables and more nuts and less red meat and healthier oils if you want to follow that healthy diet. But if you're 92, you should just be able to eat whatever you want to eat. Everybody should be able to eat whatever they want to eat. But if someone asks you, as a dietitian, we have to be prepared when somebody says, I really do want to eat what's recommended for my particular disease state. A menu option's a way to go. So, as I told you before, what's it doing? Oh, okay. So I find this works for all these different things: heart disease, vegetarians, healthy eaters, diabetes, all kind of adds up to the same diet. How well accepted is it? So I think I told you originally when I'd have to go talk to people about a cardiac diet, how many of them wanted it? Hasn't changed that much, I'm sorry to tell you. For customer service and making people happy that are a little younger and vegetarians, it's great. But the fact is, we keep track of every single person that we give that diet, that menu option to, and the education to. Number one, what is their age? What's their diagnosis, male, female, and did they accept the diet or not, and or the menu or not, and did they accept it in full, or did they want to alter it? Because a lot of them will say, "Oh, I'd really like that rice bowl, but I want to be able to bake it in the morning." So the number of people who actually choose it unaltered is under 5%. The number of people that choose it with a few alterations, who mainly are ordering off of it, is under 20% of the people we offer it to. And it's the people who most need it, if you look at their diagnosis, are the ones saying no. The people who have especially the ones who have a whole bunch of complications. They have diabetes and they have heart disease and they've already got heart failure. They're the ones who, they don't even want to look at it, frankly. They just say, no. So, dietitians, it's still a struggle. And these aren't necessarily old people in our rehab. Like I said, I'm often talking to somebody my age or younger. But it's, it's their choice. It's our choice, each of us, what we want to eat or not eat. And you know what I think we are doing by giving them the choice is we're making them happier with our health care and with our food service. Because as working for a food service company, it's really hard to make people happy with the food you serve them when you're insisting on feeding them something they don't like. So we don't do that anymore, and we have options for people with specific healthy choices. Let me talk for 1 second about sodium, because this is a tough one. And this one we got hit by surveyors just a couple years ago in assisted living. And what we got hit for was because we weren't making it clear to our residents what the high sodium items were. So we have done that now. And first of all, so you know what the recommendations are. Like I said, it's kind of ridiculous, but the USDA came out with 1,500 milligrams. Nobody's doing it. It's virtually impossible. And so I'm pretty sure it'll get thrown away the next round. But everyone's kind of sticking with that 2,300, which is a teaspoon of salt a day. Pretty hard to do with any kind of processed food. Interestingly, the one that they continue to order 2 grams sodium for is heart failure, sometimes renal, but often heart failure. The Heart Failure Society of America says stay under 3 grams. They don't say 2 grams. Their recommendations are not 2 grams, so I don't know why everybody keeps still saying 2 grams. That one I can definitely give you. I've handed it out to many a physician because the research doesn't stand by it. It just doesn't. So, and under 3 grams, that's reasonable. You know, that's pretty much what everyone else is doing. So does this mean we don't have corned beef or bacon? Or no, of course not. They'd throw out our food service company if we did that. But we do make it clear. So we have that's actually from what we post in the cafeteria on the left. So we put little salt shakers on there to let people know what the high sodium items are. So in general, if you eat there, it's low sodium, knowing that we make all our soups from scratch and we make our salad dressings from scratch and we don't use high sodium bases and all that, you'll have that 2,300 milligrams. But if you decide to have the corned beef sandwich for lunch, then then you might be getting up there. So the surveyors were happy with as long as we were labeling it so people could make their own decisions, because that's what this is about, making their own decisions. And then we have a little education piece the dietitians use to talk to people, because we actually get a fair amount of people in our assisted living who want to watch their salt. Their doctors have told them, you need to watch their salt. They want to watch their salt. And so we use this to go through the foods they should avoid and talk to them about how to read the salt shaker label. Okay, so this is my last slide. Ooh, I'm doing good. Okay, so the journey continues. As I said, we, even though we don't have a ton of people taking it up, I certainly am not ready to get rid of it, because it makes the people it makes happy, it makes them really happy. And we end up using pieces of it for other things. So our journey continues with continued QI to keep talking to people about what they want to see on there and what they don't, basically through patient interviews. Continuing to educate the nursing and dining staff. This is not a one-time thing. I said this is, as Diane and I both told you, some of these ideas have been around for 15 and 20 years. We've known better for 15 or 20 years. It's very hard to get out of their practice. It's kind of scary. So we have to keep educating. And all of you, I hope you're going to go out there and be an apostle for teaching people what's real and what isn't, because diabetes diet isn't real, and they need to know that. So continuing to educate. We get a new physician in. I had a physician one day call down, and I can't remember. She wanted some crazy diet thing, and she's like, oh, that's right, this is that place that doesn't do diets, and she hung up on us, which was not acceptable. So I went to talk to her about it's not acceptable to hang up, and talk to me about your problem with our diets, but don't hang up. That's not okay. So it goes, and she's not that old, it goes on, that every time we get a new provider, often when we get new nurses, because they've been in the hospital giving out people cardiac diets, we have to keep educating. We have to keep educating them about the Pioneer Dining Standards and choice and how this really has changed and evolved, and for me to keep educating them about what are the actual guidelines. Keep trying new menu items. If people, we get return customers quite a bit, and we do have some people in long-term care that choose some stuff off the long-term care or off the heart healthy option. So you want to keep having new ideas, new menu items. The newest one, like I said, was some homemade salad dressing, which was really well received. And Oh, continue to look at the research, read the research. It's so easy. Just go to the diabetes website, go to the American Heart Association website. It's all there. The PDFs are free. And anybody can read what I've just been telling you. And when the U.S. Dietary Guidelines come out, I'm sure it'll be all over, so you can go to their website. You can sign up for their emails if you want to know what's going on. And we continue to have to look for that new generation that that are coming in dribs and drabs, at least from what I've seen. Our assisted living, the average age is 92. So I keep hearing that we're going to get those newer people that want a different kind of menu. Mostly we just get them in rehab, but I may be retired by the time we get them. I'll probably be one of those people. Okay, so thank you very much, and questions? Okay, so the question is about farmed salmon. Much to my consternation, we do indeed do farmed salmon because it's just too expensive. It doesn't have the same omegas. When people ask me, and they often do, I'm honest with them and tell them, yeah, it's farmed. Is it still better than eating red meat? Probably. But you know what we do have now that's interesting? Our burgers, our burgers are from grass-fed cows. So I often use that to say, yes, there is some good evidence. You know, it's not totally solid, but there's growing evidence that grass-fed cows don't have the same negative effect on your heart as grain-fed. So one's getting better, the other, you know, in our salmon, it's just, I live in salmon land. Our salmon are going away. We're struggling. Our poor orcas are dying because they don't have enough salmon. So I don't know. I don't know what to do with that. Oh, this is the one thing I can say, though. Our salmon burgers are wild salmon. So I tell them that, too. And they're probably going to go up in price, Sean, but we need to keep the wild salmon burgers. So that's, where do they get it? Well, we do try to use walnuts. And so I talked to them about that there eventually becomes omega-3 of the conversion. We have tuna on there, not the highest, but it has some omega-3s. But yeah, that's about it. But it's still a little higher than our other menu. So, and there's good evidence in vegetarian studies that if you eat enough vegetables, you actually get that linolenic acid that gets converted to omega-3. There's not a study yet that's been shown to prove that taking omega-3 does anything, so we still see people on that. Do you have any questions? You can have a question of Diane, too, if you... Okay, well, thank you very much. I got you out of here, 10 minutes early. Hope to see you at the reception.
So I want to thank our two presenters for the really excellent presentation. Before you leave, you're going to need to know the code to put on your forms, and that is small case BIT. If there are any nurses here, you're going to need to fill out the evaluation form, so come up and see me about that. And people would really appreciate it if you'd fill in the 5-star evaluation form on the app. 50 years ago in medical school, we got 1 hour of information on diet. My students now tell me that they get 3 or 4 times that amount of information. So any information that you give your docs is just really important. The good docs will really appreciate it. The intellectually engaged docs are going to appreciate argument. And the ones that shut you down and hang up are insecure, and they need your feedback more than anyone. So, you guys taught me stuff, and I really appreciated it. So, thank you all very much, and